Hello everyone and welcome to today's video on APRV. So let's get right into it. We are going to establish a basic definition for APRV. We are going to describe how APRV works in relation to mean airway pressure, tidal volume, autoPEEP, those kind of things. We're going to recall what the standard settings for APRV are. We are going to assess a patient on APRV, including looking at all the various parameters such as intrinsic PEEP, looking at the trap, driving pressure, compliance, those kind of things. We're going to then recall management strategies for APRV, including what you do for weaning, and we're also going to examine the evidence for APRV. Now, before I jump into the slideshow, I want to say a couple of things. First of all, this video is going to be kind of three parts. I'm going to start, first of all, with the slideshow, kind of going through all of the words, all of the information. Then the second part, I'm actually going to show you on a ventilator simulator what APRV looks like. And I'm going to show you all of the things that we just talked about to kind of make it easier to process. And I want to do that because I feel like APRV, in reality, actually doing it, it's not that complex, but if you've never done it before, if you've never seen it before, you're new to it, it's kind of a lot to dig into, and understanding the physiology and understanding what's going on, like there's a lot there, so it's really useful to kind of look at that. So I do encourage you, if necessary, watch the first part of the video, watch the next part where I go in and look at it, but then go back to the first part again and read through it, and you might better understand kind of what's going on once you actually visually see it, right? And then the third part, we're going to go back to the slideshow. I'll have a couple more slides talking about basically efficacy of APRV. And the second thing is that APRV, even though it's been around a long time, is still kind of experimental. It's still kind of the wild, wild west. Like, we actually don't have really much, if any, high quality evidence suggesting that it works, and that's something I'm going to get into at the end of the video, but I just want to say this up front because I need you to understand that anything that I talk about in this, especially talking about settings and weaning and how do you set this and how do you this, that, and the other, and like what should our trap be, those kind of things, all of that is educated guesses. It's not, it's not law, right? It's not set in stone because we don't have a lot of good data at this point in time. So take everything with a grain of salt. And also, in the real world, if you are discussing things with your colleagues, you have a patient on APRV, try to be open-minded. Don't take things as gospel, right? When we talk about weaning with the drop and drag, like, once again, there's no evidence to suggest that that's necessarily how we should do things, right? There's no evidence, there's nothing that says you have to set APRV this way or you have to set it that way. So, have open discussions about those things, and just try to keep that in mind, be open-minded, and realize that people, even really good RTs, really good pulmonologists, providers, all these people, might say wildly different things on APRV, because once again, even though it's been around a while, in some ways it's still kind of new and experimental. So just keep that in mind, okay? Now let's get into this. Okay, so what is APRV? Well, the acronym stands for Airway Pressure Release Ventilation. So in simple terms, the way I like to explain APRV is that it is a pressure control mode of ventilation where you have two levels of CPAP. You have two levels of continuous positive airway pressure. You have a high CPAP level, we call that P high, that we hold for a long time, right? So the ventilator will go ahead and initiate the breath, if you want to call it that, and hold the patient at P high for a long time. We call that T high. And then every once in a while, you go down to the low CPAP level, also known as P low, sometimes it's called P PEEP, something like that. And you hold that for a short amount of time, or T low, right? So you are at P high for T high, and then you are at P low for T low. And you have those really, really short releases to your low pressure level. And essentially, the tidal volume you're going to get is generated by those releases from P high to P low. And that is kind of like going from inspiratory pressure to PEEP and pressure control, right? Think about it this way. The ventilator in pressure control is going to deliver a set pressure of, I don't know, 15. It's going to hold it at 15, and then it's going to release. It's going to allow for exhalation down to, I don't know, a PEEP of 5, right? Well, APRV is kind of like that, except you're holding that high pressure level for a much longer time. You're not just holding it for 1 second or 1.5 seconds. You're holding it for 4 seconds, for 5 seconds. And you're only exhaling, you're only at your PEEP level for a very, very short amount of time, like 0.2 to 0.6 seconds. So that's essentially what it is. And on the surface, that just kind of sounds like pressure control, but inverse ratio, right? Like, okay, it's just pressure control, but you're holding the inspiratory time for a long time, right? But there is one crucial difference between APRV and actual inverse ratio pressure control. In APRV, the patient can breathe on top of the high pressure level at any time. Okay? They can breathe spontaneously. The exhalation valve is open through the whole breath cycle. So they can inhale, they can exhale on top of P high and take little breaths on top of that. And that means they do not, and probably should not unless it's necessary, be heavily sedated and paralyzed while on APRV. This is a spontaneous breathing mode. It really never gets treated that way, it never really gets thought of that way, but really it is a spontaneous breathing mode, and your patient should be 9 times out of 10 doing some spontaneous breathing on that. Now, APRV is often considered an advanced mode or a rescue mode for really 2 reasons. First of all, a lot of people don't really understand it. That's why we kind of call it an advanced mode. Really, to me, there are no advanced modes of mechanical ventilation. I mean, it's just a ventilator delivering flow to create a volume and exert a pressure. That's all it's doing, and you're just changing how the ventilator delivers that flow. There really is no such thing as an advanced mode to me. But anyway, that's a rant for another time. But really, we call it kind of a rescue mode because this is something that you would really never pick when, okay, you intubated somebody in the ER and it's like, all right, what's your initial settings? You're probably never gonna say, oh, I'm gonna throw them on an APRV. This is more of a rescue mode. This is more of a, our conventional methods haven't worked, so oh, screw it, let's put them on APRV. Let's try it. So let's talk a little bit about the physiology of APRV. So why is APRV considered a rescue mode or a higher level of support? Well, the entire point of APRV is to essentially achieve a higher mean airway pressure while minimizing some of the negative effects of that. So let's talk a little bit about mean airway pressure in case you don't already know. So mean airway pressure, or here I have it abbreviated MPAW. You can also abbreviate it MAP, MAP, but I don't like doing that because then I confuse it with mean arterial pressure, which is very, very different. Anyway, so mean airway pressure is defined simply as the average pressure applied to the lungs during mechanical ventilation. So, you have high levels of pressure, you have low levels of pressure, right? Typically, in a normal breath, let's say you have a pressure controlled breath, you're applying high pressure for a little bit of time, and then a lower pressure, your PEEP, for like a long time, and somewhere in the middle you have the average, right? You have the mean airway pressure. Now, why is mean airway pressure important? So basically, the higher the average pressure in the lungs, the more alveoli are recruited, right? Alveoli require pressure to open. And the higher average pressure you apply, typically the more alveoli will open up and recruit due to a certain point, right? So basically, recruiting more alveoli is going to do two very important things. The big one is going to improve oxygenation. The second thing is it's going to improve your static compliance, right? Less collapsed alveoli means your compliance is going to get better. It's going to become easier to ventilate. You're also increasing kind of that oxygen pressure gradient. You're also doing a lot of things that will just kind of help oxygenate, help kind of make the lungs a little less stiff up to a certain point. You can, and I'm not going to talk too much about this, but you can obviously over-distend people, right? We know you can give too much PEEP. We know you can give too much pressure or too much volume. You can do the same thing with APRV, right? So having way too high of a mean airway pressure is bad, but in general, if somebody has really, really stiff lungs, if their compliance is really low and their oxygenation sucks, they generally need a high level of recruitment. They need a high mean airway pressure in order to open up all of those diseased alveoli, generally speaking. So generally they need that high mean airway pressure. Now it's a little different if we're talking about a state where it's not atelectasis, it's fibrotic scar tissue or something like that, right? If your patient has some kind of ILD, then a high mean airway pressure might not really help because you can't recruit scar tissue, right? At least not as far as I'm aware. So that's kind of the idea behind high mean airway pressure. When you hear mean airway pressure, I want you to think of oxygenation. I want you to think of recruitment. I want you to think of trying to improve static compliance. That's what I want you to think about when we talk about mean airway pressure. APRV is all about the mean airway pressure. So really, when you think of APRV, I want you to think of oxygenation and recruitment. That's what we're targeting here. That's the goal. Now, as I already said, in traditional mechanical ventilation, there are many things that affect your mean airway pressure. PEEP is your biggest factor in conventional mechanical ventilation because you spend a lot of time at PEEP, right? You might have an I to E ratio 1 to 2, 1 to 3, 1 to 4. So really only like maybe a third of the breath or less you're actually spending at the high pressure level. So if you increase your PEEP, your mean airway pressure is going to go up more because you spend more time at the PEEP level, right? Instead of the high pressure level, right? Like inspiratory pressure in pressure control mode. But with APRV, everything's backwards. You spend a lot of time at P high and very little time at P low. So making changes to P high is going to have a huge effect on your mean airway pressure. At the same time, when you set your P high really high and for a really long time, your mean airway pressure is going to be really high. Like I said at the beginning of this slide, APRV, high mean airway pressures. That's what we're going for, right? But the thing is, mean airway pressure, once again, is not just free. We already said that you can over-distend and cause problems with that, but the other thing you can do is high mean airway pressure also increases intrathoracic pressure, right? Increases pressure in the thoracic cavity. That increased thoracic pressure basically compresses the inferior superior vena cava and kind of reduces venous return to the heart and can potentially reduce cardiac output, especially if your patient has right heart failure, those kind of things. Like it can cause a lot of problems with that, possibly. So you can end up tanking somebody's blood pressure with high levels of mean airway pressure, potentially. Now here's the thing. Remember what I said before, with APRV, it really is kind of a spontaneous mode. the patient can spontaneously breathe on top of that high pressure level at any point in time. Now let's think back. So mechanical ventilation, right? Mechanical breaths are positive pressure, right? The ventilator is applying a positive pressure to the lung parenchyma. Spontaneous breaths, on the other hand, our natural breathing is negative pressure, right? We are, the thoracic cage is lifting. That is causing a negative intrapleural pressure, which is basically causing a pressure gradient, which will then cause air to flow into the lungs via negative pressure, right? So if the patient is spontaneously breathing on top of the high pressure level, their spontaneous breath is actually going to counteract that high mean airway pressure a little bit by reducing intrathoracic pressure and improving venous return to the heart. Some studies have also shown that these spontaneous breaths do improve gas distribution and VQ matching as well. Okay, so we talked about kind of the whole mean airway pressure side of things, but there's a little more to the story. There's a little more about physiology. The next thing is we're going to talk about the release time. As this is essentially inverse ratio, you spend a really short amount of time at your T low, as we already discussed. And you might think, well, that's going to cause air trapping, right? The patient's going to autoPEEP. Exactly. This is the one time during mechanical ventilation where we actually want the patient to have intrinsic PEEP. We actually want them to be autoPEEPing. Basically, what it's going to do, it will slightly increase mean airway pressure, but really more so, it is going to prevent atelect trauma during the release phase. And so if you don't know already, atelect trauma, one of the reasons why we never set somebody's PEEP to 0 is because when you go from your inspiratory pressure, whatever that is, down to your base PEEP, essentially, if your PEEP is 0, the alveoli are going to collapse shut every breath. And then when the next breath comes in, the alveoli are going to open up, but it's going to be hard because they're all completely collapsed. So that causes a lot of stress and strain. And when that happens every breath, they snap shut and inflate, and snap shut and inflate. That causes all sorts of bad stuff. Atelect trauma is really, really bad. It'll make the ARDS worse. It's just not good. So that's why we typically set, PEEP at least at 5, if not a lot more, for these patients. Now, with APRV, you're going from that P high and releasing, the P high and releasing. And here's the thing, that's once again just like giving a breath. You have to be trapping some amount of air in order to prevent atelect trauma during that release, right? It releases, and you don't want the alveoli to collapse like that, right? So you have to be autoPEEPing to some degree. Okay, so we just talked about, mean airway pressure and the oxygenation and recruitment part, but of course the other big part of mechanical ventilation is tidal volume. Well, how does APRV generate a tidal volume to actually ventilate? So what your tidal volume is going to be is determined basically on the difference between your PEEP and your plateau, just like in any other mode, right? And we call that difference between PEEP and plateau driving pressure. However, that is not the difference between your P high and P low. That is going to be the difference between your P high and whatever intrinsic PEEP you generate, right? Because you're going to be trapping a good amount of the breath you're delivering, because your T low, the time you spend at the release, right, the low pressure, is going to be very, very short. As we said, you want to autoPEEP, right? So how much tidal volume you get is going to depend on how long your T low is and how much autoPEEP you're getting. But here, this is where it gets kind of tricky, because when you're adjusting APRV, basically every parameter can affect your minute ventilation. Increasing your P high is going to increase probably your driving pressure and increase the tidal volume you generate. Changing T low is going to change that as well. Changing P low will change that. And I'm going to talk about this in management too. But just understand, like, everything affects everything when it comes to tidal volume. And so things can be a little confusing to try to figure out. However, the patient can kind of auto-regulate a bit because this is a spontaneous breathing mode. The patient is able to take breaths when they want and can aid with CO2 clearance. So tidal volume is not just based on your releases, how often you're releasing, and what the driving pressure is during those releases. That's not the only thing determining it. It's also how much your patient is spontaneously breathing too. So of course, all of this means that there can be a big variability potentially in the patient's PaCO2 as a result. And this may not be the best choice for patients who are profoundly hypercapnic, right? However, it's okay and arguably even preferable to leave ARDS patients at a higher PaCO2 and a lower pH towards the low end, maybe around 7.30 to 7.35. In fact, I've seen some people even like lower than that, lower than 7.30, sometimes even down to 7.25. And the reason for that is the Bohr effect. Remember, as the patient gets more acidotic, oxygen will be less likely to bind to hemoglobin, which means more oxygen will offload at the tissue level, which is important when your patient already has tissue hypoxia, right? The Bohr effect is going to help combat that a little bit. So, we don't want these patients alkalotic. We don't want them anywhere near alkalotic. We want them closer to the acidotic side within reason. So, with APRV, of course, do worry about your CO2 clearance, but don't worry about it that much, right? So, indications. I mean, we've already talked a lot about mean airway pressure and recruitment and blah, blah, blah. So it should be kind of obvious at this point that the big indication for APRV is severe ARDS. You've got a patient who's got refractory hypoxemia, you've titrated PEEP and FiO2, none of that is working. APRV might be a good next step. Now, of course, there are other things we will try as well. Proning is something that does have a lot of evidence that it works. So you could definitely try proning first. Proning does require more resources, more people, and that kind of stuff, and does have some possible contraindications, but I think proning is still a good first step. There are other things, of course, you can try with these severe ARDS patients. Sometimes pulmonary vasodilators are used. I'm not going to get too into the whole, it's really just a Band-Aid if your patient doesn't actually have pulmonary hypertension. But anyway, long story short, it does tend to work sometimes. Is it really the best fix? But if you tried those things and they're not working, then a lot of times APRV is what you're going to go to next. But once again, that high mean airway pressure is good not just for patients who are in ARDS, but for anybody that's really severely restrictive but recruitable, right? Not that patient with end-stage pulmonary fibrosis, but the patient that maybe has massive atelectasis and de-recruitment, say maybe after some kind of surgery or something like that. The high mean airway pressure is going to recruit a lot more. So even if the patient, doesn't have refractory hypoxemia, if they have a really low static compliance, and it's a low static compliance that can respond to recruitment, then APRV can help with that. So we're going to talk about initial settings. Now remember what I said before. Nothing is really truly established. But let's talk about what the settings are. The settings are P high, T high, P low, and T low. And I already kind of explained that, but once again to recap, your P high is the high pressure level. You set that for T high. That's how long you hold the high pressure. Your P low is your low pressure level. Your T low is how long you hold that low pressure for. Now, some modes will also have pressure support because, once again, this is a spontaneous mode. So some ventilators will allow you to put pressure support on top of those spontaneous breaths that the patient is taking at P high. Now, here's the thing. That is a very bad idea. You should never, ever use the pressure support in APRV if your ventilator offers it. Why? Why do you not want to use the pressure support? Let's think about it. We're already trying to be lung protective with these people the best we can. If we add pressure support to their spontaneous breaths and they're already at a P high of like 30, their total pressure is now going to be a lot higher if we're now adding more pressure support. And if you're worried about CO2 clearance, there's other things you can do to help kind of clear more CO2, but adding pressure support is a very bad idea because you're going to increase the intrathoracic pressure and basically completely counteract the whole point of those negative pressure spontaneous breaths, because they're not negative pressure anymore, they're positive pressure. So now you're increasing intrathoracic pressure, you're increasing the risk for barotrauma, those kind of things, and you're increasing the likelihood that the patient's going to injure themselves by breathing during APRV. Now, book method, meaning, you're in school, what do I have to look out for when they're asking questions about APRV? Well, let me tell you, at least as of right now, in the year of our Lord 2025, they really don't ask much about APRV. You're probably, if you're an RT student, you're probably not going to get really many, if any, TMC questions on APRV. The only thing you really need to know is set your P high based on your plateau pressure from the traditional mode of ventilation. Once again, you would never start with APRV. And on the ClinSim, I highly, highly doubt you would ever see a scenario where you'd be using APRV. It's kind of a taboo thing. The MBRC doesn't really like it. They don't really touch on it much. Now, will that change with the new test coming out in the next year or two? I don't know, maybe, but I kind of don't see it changing. Anyway, let's talk about the real world. So there are basically two large studies that were done by some researchers with APRV, and these two methods that I have here, the Habashi method and the Zhao method, are the settings that those researchers used in their trials. So the Habashi method, this is kind of like the classic APRV. You set your P high as above, meaning you set it based on your plateau pressure. You set your P low as 0. You're going to set your T high to the point where it is somewhere around 90% of total cycle time, right? That's usually going to be somewhere around 4 to 6 seconds, something like that. And you're going to set your T low around 0.2 to 0.8 seconds for your restrictive patients, or 0.8 to 1.5 seconds for your obstructive patients. And I'm going to explain why in a minute. And you're going to titrate your T low to 50 to 70% of peak expiratory flow rates. Now that right there, that last line, that's kind of the most, one of the most important but complex parts of APRV. I'm going to hold off on explaining that for now because I want you to physically see it. I want you to physically see it, and if I try to explain it too much, I don't think it's going to make a lot of sense. You want your breath to terminate at somewhere around 50 to 75% of peak expiratory flow, meaning you want to trap 50 to 75%. That's all I'm going to say for now. I will show you physically on the ventilator. It will make more sense then. And that's the Habashi method. The other one is the Zhao method. We set the P high, the same thing, based on P plat, but no greater than 30 centimeters of water. Then you are going to set your P low to 5, and you are going to set your T low to 1 to 1.5 times the time constant, the expiratory time constant. Now, I'm not going to explain time constant in this video because this video will end up being 3 hours long. But time constant is essentially the time it takes for the patient's lungs to fill and to empty. That's the time constant, right? And so you can calculate the time constant. Some ventilators do it automatically, and then you set your T low to 1 to 1.5 times a time constant, and then you're going to titrate it to get a trap greater than 50%. Then your T high, you're going to titrate that so that your release frequency, aka your respiratory rate, is 10 to 14 per minute, and you're also going to try to get the patient to have a spontaneous minute ventilation of about 30% of the total minute ventilation, meaning you want to encourage the patient to be breathing a bit on their own. So as you can see, the Zhao method here is quite a bit more complex. We're still titrating our T low based on trap, but we're setting it more precisely based on time constant versus just setting it based on some arbitrary, 0.2 to 0.8 seconds. And we're targeting a specific release frequency of 10 to 14 rather than a specific T high. And then also, notable difference here, P low of 5. Now, here's an interesting thing, and this is kind of a debate. And once again, I don't know what the right answer is because there's not enough clinical evidence to say. But let's think about this. You might say, well, you can set your P low to 0 because you're auto-peeping anyway, right? So why would you set your P low to 5? Why does it matter? You're auto-peeping. Who cares? Like, is the 5 going to make a difference? Well, here's the thing. As your patient's lung compliance changes, the auto-peep and the amount of air that you're trapping, your trap percentage, is going to change. So having a P low of 5 is kind of a way to just ensure that the lowest you can ever get is 5. The P low of 5 is probably not going to hurt anything. Probably not. But it's almost more just like a safety net. I personally think P low of 5 is just fine. I don't think it will hurt anything. Is it helpful? Maybe not. But will it hurt anything? Probably not either. Once again, this is all hearsay. There's really no evidence. The other interesting thing here about the Zhao method is encouraging the patient to breathe spontaneously. That's a big part of it, and I think that is super important to notate. So now we're going to talk briefly about what kind of things do you do to assess a patient on APRV. What do you look at? Well, you look at all the typical things you look at for any patient that has ARDS. You look at their PF ratio, their static compliance, their driving pressure. You want to be looking at their chest x-ray and CTs to see how bad their lungs look. Do they look like they're under-recruited, that kind of stuff. You want to be monitoring their hemodynamics, of course, their PaCO2, and their overall acid-base status. Once again, we want to keep them a little acidotic, but a lot of times these severe ARDS patients have a lot of other problems going on. There are multiple insults at the same time a lot of times. Their kidneys might be shutting down. They might have a bicarb deficiency, right? If that's the case, we don't want to push them over the edge, right? We might actually have to worry a bit more about ventilation there. Stuff like that. The biggest thing to watch on the ventilator is the trap percentage. I'm going to give you the balloon analogy for compliance. So think about this. Think about a brand new balloon. When you blow into it, you try to blow it up, it's really stiff. Like if you take one volume of breath, one pressure of breath, it goes in really quickly, but it doesn't blow it up very much. And then when you release that balloon, boom, it snaps shut really quickly, right? Because there's so much elastance. There's so much elastance in that balloon. Like it wants to let the pressure go. So as soon as you release, boom, it collapses. Whereas an old saggy balloon, you take the same amount of breath and it blows up slowly. It fills more space using that same amount of pressure. And then when you let go, there's not as much elastance. So when the balloon empties, it empties slower because it's not as elastic anymore. It's kind of old and worn out. So lungs are the same way. Really stiff lungs. Your severe ARDS patient with low compliance, their lungs empty quickly. As compliance improves, the lungs will empty slower. Or as the lungs worsen, they will empty faster. So once again, time constant, I'm not going to explain every detail about it, but it's how quickly your lungs fill and empty. It's that balloon analogy. And so your trap percentage and your autoPEEP, that is your time constant, right? Because if you release the breath for 0.2 seconds, the amount of air that is released, the amount of ventilation you have, the amount of air that escapes from the lungs is going to be determined by how stiff those lungs are. If the lungs are really stiff in that 0.2 seconds, they're going to release a lot, and you're not going to have much autoPEEP. You're not going to be trapping very much gas. But if the lungs are very compliant, not very much is going to escape in that 0.2 seconds. You're going to trap a lot. Your autoPEEP is going to be really high. So when your lungs get better, your autoPEEP is going to get higher, and your trap percentage is going to go up. Once again, if that doesn't make sense, I will show you on the ventilator. But that's what we're talking about. Healthier lungs empty slower. Healthier lungs are going to trap more. Unhealthy lungs are going to trap way less. Let that simmer. Think about that. Let that simmer. Now, management. I already talked a little bit about this, but let's get into it more. So, Leave these patients alone after initiating APRV. Look, they need time to recruit. And this is not, once again, this is not scientific, this is not backed by any data, but think about it. If you increase somebody's PEEP, you don't tend to see the effects of it immediately. It takes some time for their lungs to recruit. I mean, you might see a little bit of change immediately. You might see an instant change in their compliance, but usually if you leave them alone and you let them recruit over time, you're going to see a much bigger change. Same thing with APRV. Don't make any changes unless absolutely necessary for at least like a shift or two. Preferably a full day. Just let them marinate, let them recruit, and hopefully they're going to get better. That's the biggest thing with management. Just leave them alone. But the most complicated thing about managing APRV, as I said towards the beginning of this video, is that every setting you change will alter several things. Changing your P high will affect your mean airway pressure and your tidal volume, right? Because higher P high is going to mean more mean airway pressure. Higher P high will mean higher driving pressure, more tidal volume. T high is going to affect your mean airway pressure a little bit. Not a ton, but it'll affect it a little bit, but it will also affect your minute ventilation. If you change your T high, that's going to change your total cycle time, right? If you lower your T high, you are going to have a faster rate because your total cycle time is going to get shorter, right? Changing your P low is going to possibly affect your mean airway pressure depending on what your autoPEEP is. Besides that, honestly, P low doesn't really change that much. We don't really change P low normally. And changing T low is going to affect a whole bunch of stuff. Changing T low affects everything, okay? Changing T low is going to affect how much you're trapping, right? Your trap percentage. It's going to affect your total PEEP. It's going to affect your tidal volume, your driving pressure, your mean airway pressure, right? If you have a longer release, meaning you stretch out your T low, you are going to trap less air. You are going to lower your intrinsic PEEP, which is going to slightly lower your mean airway pressure. That's also going to raise your driving pressure. That is also going to raise your tidal volume, right? Because there's more emptying going on in the lungs. This is the last slide before we actually jump into the vent, okay? We're talking about weaning. So when we talk about weaning, we typically talk about drop and stretch. That's what we do. But first, before we drop and stretch, before we get ahead of ourselves, you want to get your FiO2 down to 40 to 50%. Once you're able to do that, you can say, okay, the patient's oxygen demand is decreasing. I can probably start to wean them more. Another thing to look at too, I suppose, would be static compliance. If their static compliance is starting to improve as well, it's not, 12 anymore. It's now 25, 30. Okay, all right, maybe we can start to wean a little bit. So once you have your FiO2 down, you're going to gradually lower your P high by 2, and you're going to lengthen your T high by about 0.5 to 1 second. So you're going to be dropping the mean airway pressure, but only by a little bit because you're going to lengthen T high. So really mean airway pressure, it'll change definitely, but it's not going to change too crazily. And if we lengthen the T high, our total cycle time is longer. We are going to have a slower release frequency. We're going to have a lower respiratory rate. And lower P high also is going to mean less tidal volume generated as well. What does this mean? This means the patient has to be breathing spontaneously to some extent, right? Because if you keep dropping P high and lengthening T high, and the patient isn't spontaneously breathing, they're going to become profoundly acidotic because their minute ventilation is going to drop. You're releasing less frequently to lower tidal volumes. But if they're breathing spontaneously on top of that P high, then dropping and stretching is going to work effectively. And the idea is you drop and stretch to gradually transition the patient to doing this spontaneous breathing, and eventually they're basically on CPAP mode, right? They're pretty much on CPAP. By the time you get down to a P high of like 15, and your T high is really long, it's like, 8, 10, Like, at that point, they're basically on CPAP. You might as well switch them to CPAP. You can pretty much just throw them on pressure support or CPAP mode and wean them like normal if they're healthy enough to tolerate that. That's basically how the weaning works. Okay, so now let's do what we've all been waiting for and actually put a simulated patient on APRV. So here's just some very generic settings. We're doing a P high of 30, P low of 0, T high of 4.0, T low of 0.4. So these are, once again, just very generic settings. We're going to throw this patient on here, and I'm going to show you how it works. Okay, I now have the graphics where I want it. It looks pretty good. So first, let's kind of look at what's actually going on here. So here you have your P high, right? Your P high of 30, and it's held for T high of 4 seconds. We have a brief release to P low for T low, and this is all on the pressure waveform. Now let's look at our volume waveform real quick. We can see a tidal volume goes in, we kind of get to our max tidal volume, and we hold it there, and then we exhale. Right? And then we have another volume, and we exhale. Now let's look at our flow. So here we have the start of the breath, we have flow going into the lungs, and because it's holding that pressure, the pressure gradient between the alveoli and the ventilator slowly decreases until we plateau. We hit this plateau where there is basically no movement because the pressure in the ventilator that the ventilator is giving of 30 is equal to the pressure at the alveolar level, which is now also 30, so there's no gas flow anymore. And then boom, we have a release. And you can see, now once again, this is a computer, this is a simulation, this is not a real patient, so our flow waveforms look beautiful and perfect, and there's no wackiness going on at all, because this is a simulation. In real life, it's going to look more messy, but this is good for learning. So you can see, boom, we exhale, and our peak flow is really, really high at first, right? Our peak flow is really, really high, and then it starts to decay. And then over here, you can see all of a sudden, boom, our flow goes way back up to positive. This is where the next breath starts. That's where the next breath starts, approximately. Okay. Why is this important? We're going to talk about the trap thing. Okay? Remember when I said trap percentage? I'm going to talk about it. This is why I'm talking about it. So remember, basically the scientists, the ones doing the study, they were titrating their T low, the time spent at low pressure, so that the breath terminates at 50 to 75% of peak expiratory flow. What does that mean? So this over here at the very start of your breath, this is your peak expiratory flow right here, negative 137.8. That's peak expiratory flow. And then flow slowly decays. The flow starts to go more positive until the next breath starts. So you want the next breath to start when this flow waveform hits 50 to 75% of peak expiratory flow. Now really, real quick side note, I know those studies said like greater than 50% peak expiratory flow, 50 to 75%. But I have heard, I've seen other studies say, and I've heard in the real world, usually we want to target 75% of peak expiratory flow. And once again, I call this trap. We want our trap to be 75%. Trap is the term we use at the hospital where I work. Is it scientifically correct? No, I don't think so, but I think it also makes it kind of easier to understand and just easier to talk about, either than saying the ratio between peak expiratory flow and end expiratory flow, because that's really what it is. It's the ratio between peak expiratory flow and end expiratory flow. But that's too complex. We just call it trap, okay? So anyway, going back, peak expiratory flow, negative 173.8. And then we can see over here. So you might go, okay, well, when does the next breath start? Oh, is it there? Is it there? Well, here's what I want you to look at. So look at the actual, I'm pointing at the screen as if you can see. Look at the actual numbers for flow. You can see it decays really slowly, right? 107, 103, 100, 96, 93, 90, 87, and then 67. All of a sudden, the flow goes down a lot, right? You go from the 80s to the 60s, 87 to 67. So really, right here at 87, that's probably where the breath ends. Because before that, we have a nice, not exactly linear, but close to linear slope of how the flow decays as the patient exhales naturally, right? And then all of a sudden, we have a big change in that. We go from 87 to 67. That is probably where the next breath starts. So we're going to now do some calculations. So what do we say? 87.2. Here's my little calculator. 87.2 divided by, what do we say? 173. I have the memory of a goldfish. 173.8 divided by 173.8. That right there is our trap percentage. We are trapping 50%, just about exactly. Now, technically, you know, according to those protocols, that is technically okay. But once again, really, we kind of want to get more towards 75. But before we get ahead of ourselves, let's talk about what I would do in the real world when looking and analyzing the trap, right? So we're trapping 50-ish%. But here's the thing, once again, as I said, in the real world, this is going to be a lot more messy. I would maybe look at a couple of breaths and make sure they kind of line up about the same, right? Now, different ventilators should all have a way to be able to kind of like freeze the screen or take a screen recording so you can look at the flow waveform. The ones I typically use at work are servos, and you take a screen recording, and then you can like go back and look through the recording. And I just try to look for some good, clean breaths to analyze. But I would compare a couple breaths. Like, here's the other breath, 173.8. And then we terminate at 87.2, exactly, because this is a computer, it is a simulation, and every breath is exactly the same, right? In real life, these would probably be a little different. They would look slightly different, you know, and you kind of compare them and go, And, you know, breath to breath, it's going to be a little different. And you're going to be like, oh, I don't really know. You know, you might have a little bit of a dilemma with some of that. So, really, measuring your trap is kind of subjective. If you take 5 people and show them one vent with the expiratory flow waveform, you might get 5 different calculations for your trap. Because one person might say, you know, one person might be like, oh, no, it terminates here. And the other one says, no, it terminates here. No, it terminates here, et cetera, et cetera, et cetera. And it's hard to tell really who's exactly correct. So how can we kind of determine how our trap is correct? Well, the best thing to do is trend it, right? Let's not talk about trap for a second. Let's kind of talk about other parameters for APRV, right? We kind of explained trap. The other things we want to look at, we want to look at our driving pressure. We want to look at our autoPEEP. We want to look at our compliance. I did this on a simulated patient with a completely normal compliance, and we can see their static compliance is completely normal. We are auto-peeping. We have an intrinsic PEEP of about 15. And because our P high is 30, that means our driving pressure is 15. Right? We're getting volumes of 862. We have a respiratory rate of 14. And our total minute ventilation is 11.8. We're getting great volumes on a low rate. Our driving pressure is, this is technically dangerous. We want it under 15, but it's, you know, it's borderline. And we have pretty good compliance here. So back to the whole, can't really trust the trap. It's kind of subjective to measure. Well, here's the thing. Let's start changing stuff, and I want you to see how things change. We're going to take our T low, and we're going to drop it. I'm going to drop it by a lot just to really demonstrate the effect. In reality, would you make this big of a drop? Probably not, but this is just to demonstrate. Okay. I want you to watch the waveforms, watch how they change. Right there, you can see it. The release is a lot quicker. So give it a minute. Let things stabilize. And same thing in real life, you would let things kind of stabilize. Because, you know, this is a computer and it does react instantly, but a real patient's lungs are not going to react instantly. We're going to look at everything that changed by lowering our T low. So we can start by looking over here. Our tidal volume, it was 800 something before. Now it's only about 500. Our respiratory rate has stayed the same because changing by 0.2 seconds is not going to change our total cycle time very much. So our respiratory rate shouldn't really change. But our minute volume is way less now because our tidal volume is way less. Well, let's see what else has changed. Let's look at our trap now. Okay, so now we have 173.5. And we terminate 115. Wait. 115.95. Look at that. 124, 120, 115, 95. Huge drop of 20 points. So now we terminate at 115.9. So 115.9 divided by, we are now trapping 66, about 69, nice, percent. 69%. And once again, so like, it's one of those things where you can see that everything is skinnier, right? You can see that the area under the curve has changed, right? Like, this is a lot deeper now than it was before. So, you know, we can measure our trap and see that it's changed. But if you're unsure, if you're like, God, I don't know if the trap is correct, you can physically see a difference. You can see that the flow terminates at a lot higher level, right? So even if you're not 100% sure of what the exact flow is, you know that, okay, we are definitely trapping more, right? Now let's look at a couple other things. So, look at our autoPEEP. Our autoPEEP is now 20, almost 21, whereas before it was just below 15. So that means we have a lower driving pressure. Our compliance, on the other hand, has gone down slightly. It hasn't really changed because our tidal volumes are a lot lower now too, right? Now here's the thing. If our autoPEEP increased and our driving pressure decreased, and our tidal volume stayed the same, our compliance would be a lot better. But that's not the case, right? Our tidal volumes have dropped in line with our driving pressure, which means our compliance is about the same. Are you starting to see how all these things kind of go together? Are you starting to see how changing things changes everything, right? We have affected our ventilation by quite a bit. Now, oxygenation, here's the thing. Our P mean of 29, what was it before? Was it still 29? I'm going to be honest with you, I didn't even look at it, but let's go back just to see. Yep, and see, you can see the difference. Look at how long that is, how deep that is versus this. This is way less deep, right? You can just see, even if you don't know exactly what the trap is, you can see it's way less deep. Give that a second. Yeah, see, our P mean has dropped by quite a bit because our autoPEEP has dropped, and we're also spending more of the breath at P low as well. We're spending more time at P low. So you can see T low affects everything. That's lesson number one. Well, I guess lesson number one is trap is kind of hard to measure. I showed you how to measure it, but it's kind of hard to measure. You really kind of have to trend it with other things. Lesson 2 is changing T-low changes everything. And remember, we want to target allegedly 75-ish% of trap. That's kind of what we want to aim for. So if you want to change T-low to try to clear more CO2, that's all fine and dandy, but you're going to increase your driving pressure. Okay, you're going to increase your driving pressure, and you're also going to reduce your autoPEEP and your trap, and that might end up causing some atelect trauma, potentially. We can also go the other way on T-low, and you will see the opposite effect. Let's go up to 0.7, sure. Let's go up to 0.7. Look at the difference. Look how deep that is. Look how deep that is. Even if I don't exactly know what my trap is, I know it's a lot less. But let's measure it. 174.1, 52, 38. Oh, see. Sorry. Oh, 57.2. We're only trapping 33%. We're only trapping 33%, okay? Not only that, our autoPEEP is only 9. Our driving pressure is now 21. Our compliance actually increased a little bit. We're getting a lot more CO2 clearance, and we're getting a little more bang for our buck. But we are at an unsafe driving pressure. Our mean airway pressure has dropped more, and we're probably causing atelect trauma on top of all that. So, not good, not good, not good. Right? Let's set this back to 0.4, back to our standard, and let's change some different parameters and see what that does. So now, we'll give it a couple breaths, let it get back. Now I'm going to show you what changing our P high is going to do. So, let's now bump our P high up. Once again, I'm going to bump it really high for dramatic effect. No, actually, no. I'll be realistic. Right now, our P mean is 27. Driving pressure is 15. Tidal volumes are mid-800s. Static, 56, 57. Keep that in mind. Let's bump it by 2. Okay. So, first of all, let's look at our trap. Let's see if that did anything to our trap. 185.3. So our peak expiratory flow is now a little bit higher. 185.3. 91.70. I'm going to call that probably. Because that's a big drop, because we go hundreds, we go 90s, and then straight to 70. So 91.8. 185.3. 49 and change, almost 50. And what was our original trap when we were on 0.4 and 30 and T high of 4? It was about 50, right? So really, our trap has changed by a negligible degree. Trap has changed negligibly. What about everything else? Okay, well, our driving pressure is a little higher. Our autoPEEP is slightly higher, but see, we increased our pressure by 2, and our autoPEEP only increased by like 0.7, so it really didn't increase that much. Like, we're trapping a little more gas, but not much more. And the actual percentage we're trapping is negligibly less. Our driving pressure is a little higher. Our static is about the same, maybe slightly lower. Our minute ventilation, our volumes have increased by a little bit. Our mean is now 29. It was 27, it's now 29. So we have increased oxygenation, right? We have increased our ventilation as well. We haven't really had too much of effect on like atelect trauma or whatever, but we have increased our driving pressure as well, right? So things have changed a little bit. You can kind of see how that affects it. Now let's change our P low. Let's see if that changes anything. Okay, so let's measure our trap. 144.8. So it terminates. Our flow is a little bit lower. 53.1 is probably, no, wait, 70, yeah, 72.1. So our trap is, once again, negligibly different. It's about the same. Right? We're trapping about the same amount of the breath. However, our minute ventilation has dropped. Our volumes have dropped. Our static compliance is about the same. Our driving pressure is a little bit lower. So adding some, and our P mean is a little bit higher at 28 now. So having that extrinsic PEEP, that PEEP that we're giving them, so now our autoPEEP is a little lower, but our total PEEP is close to the same. We can see that we have maybe slightly affected oxygenation, had a bit of an impact on ventilation as well, but it hasn't really done anything for trap or anything like that. So changing P low actually does have a little bit of effect. Now, once again, your mileage is going to vary based on your actual patient, but this is just kind of generally what it's going to do. Okay, now we're going to look at T high. What happens when we change T high? So we're going to drag T high out by like 2 seconds. Pretty big jump just to see. Remember, we have normal mean at 27, autoPEEP at 15, blah, blah, blah. Minute vent 11.8. So let's just give it a few breaths. Let's see what happens. Obviously, I dragged it out by 2 seconds, which is a big change. But we can already see, look, our respiratory rate has gone down to 9. Our minute vent has gone down to 8.1. Our volumes look about the same. I'm not going to calculate our trap because it's just a waste of time. 173.8, 86.6. It's about the same as before. I can tell you just by looking at it, it's about the same. So it hasn't really affected trap. autoPEEP, negligibly different. Our mean airway pressure went from 27 to 28, so it did go up, but our minute ventilation dropped. So, real quick, before I get into the compliance aspect and as your patient changes, blah, 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 what is a common theme that we're seeing here? What is a common thing? Things that increase your mean airway pressure tend to decrease your minute ventilation, usually, except, P high, a little different, but that increases driving pressure, so that's a little different. But everything else, if you're changing your timing, right, if you're changing your T low, your T high, that is going to alter your mean airway pressure. You might get more or less oxygenation, but you're also going to get more or less ventilation. Now, once again, if your patient, remember, this is a computer simulation. Okay, the patient is not spontaneously breathing at all. But if this was a real patient and you're doing the right thing and not paralyzing them and letting them breathe on their own, then they should be making up for some of that. And you might be able to sacrifice a little bit of minute ventilation, right? That might be okay. But just keep that in mind. Everything affects everything. Every time I change a parameter, pretty much everything on here changes. Well, okay, with T high, not everything changes, but your mean changes and your ventilation changes. It doesn't affect your autoPEEP, doesn't affect your trap, but it affects those other things, right? So let's go back to our baseline settings. We'll let it get back to that. And then what I want to do is I want to show you what happens when the patient's compliance changes. So that's the cool thing about this. I can go in here and I can take their compliance and change it myself. So I'm going to change it hugely for dramatic effect, just so you can see. I'm going to make a huge change to their compliance for dramatic effect. And what I want you to focus on right here is this flow waveform. Watch the flow waveform as the patient's compliance changes, right? You've already watched the flow waveform as we change T low and those kind of things and see how that changes it. But watch what happens when our compliance changes. Are you noticing a difference? Are you noticing that now this curve is not as deep as it was? So obviously, and I'll give a couple more breaths, but you can see obviously our volumes are dropping. You would expect that from lower compliance, right? Low compliance means you're going to get less volume for the same pressure, right? Or you have to have more pressure to get the same volume. We know that. So you expect this to go down. Let's look at the rest of the story, though. Well, first of all, let's measure our trap. Oh my god, look at that. What happened? Oh boy. Let's try to measure our autoPEEP. Ay, ay, ay. So, or I'm sorry, let's try to measure our trap. Our peak expiratory flow to end expiratory flow ratio. So we have negative 154.1. And we can see that now the flow is going back to zero quickly, but we can see that it's fairly linear, right? There's not really any crazy jumps. 27, 23, 20, 17, 14, 12, 10, 9, 8, 6. There's the next breath. 6.9. Nice. Negative 6.9 divided by 154. Oh my god. Do I even need to do that math? We're trapping 4%. Why did I just close my calculator? Why did I do that? Anyway, so remember what I said earlier. This is a stiffer balloon. This is a stiffer lung. The flow comes out way quicker. We haven't changed our T low at all. We haven't changed anything. But what happened is the flow comes out a lot faster. And you might say, well, but the volumes are smaller too. Right? The volumes are smaller. Look at this. Oh my god. autoPEEP 1, driving pressure 29, static compliance at 12. That's terrible, right? Oh my gosh, that's terrible. Tidal volume's only 300s. Minute vents 4.7. You might say, well, the volume's dropped, so yeah, like the flow is going to come out a lot sooner because like there's less volume in the lungs. Well, couldn't you just bump this up and you would trap more, right? Because you'd get more volume, right? So let's, once again, never do this to your patient. This is just for dramatic effect. Just for dramatic effect. Well, let's bump it up. Let's get bigger volumes. Isn't the flow going to come out slower? Right? Bigger volumes. Flow should come out slower. I don't know about that. Let's look. Well, we have a bigger volume now. We're also killing our patient. And our static is now 8. I'm not going to measure it, but like, look. So 287. Where does it terminate now? -4, -3, 24. We're actually trapping less. We're trapping less than 4%. 3 is what percentage of 287? Like barely more than 1%. We're actually trapping less. So bigger volumes isn't helping. It's not helping us trap more, right? Okay, so that's not working. The volumes are not making any difference in trap. Like, what the heck? So that's super bad. It's because the lungs are snapping shut quicker. It's a stiffer balloon. Well, what can we do? What do we do? What do we do with this patient? Their compliance is so terrible. What do we do? Well, in order to get them to trap more... Oh, also, I'm sorry. I kind of got ahead of myself. Let's look at what's our mean and everything, right? So, mean is still 27, right? Compliance is 12, driving pressure 29. So, our mean hasn't changed, but our autoPEEP is basically nothing. Our trap is basically nothing. Well, let's cut down the T low. Let's try to get a higher trap, a higher autoPEEP. Let's do that. Let's see what happens. Give it a few breaths. Okay. Okay, now it's not terminating at 0 anymore. It's, terminating somewhere. Let's just see. Okay, so we have an autoPEEP of 5. Our driving pressure is now... Oh, it's going up still. Let's give it a second. Let it work. Oh, I know. You poor guy. So our autoPEEP is now 5. Our driving pressure is now 25. Static's the same. Tidal volumes are even smaller. And now 153.8. I'm going to call that 26. We can see that we are trapping a bit, right? 26 into 153. So it's not much. It's maybe like 12%, but it's something. We're trapping something right now. You can't go any lower on T-low, right? You can't do anything else there. You might have to actually go up on your P-low if somebody was this bad, right? You might actually have to try to do something there. This is a really, really stiff patient. Let's go back here. Let's take their compliance first back to 100. So you can see that. And then we're going to take the compliance over 100 and have the compliance be even better. Oh, by the way, this right here, RC expiratory, I'm pretty sure this is like the time constant for expiration, I believe. And you can see, as compliance increases, our time constant gets longer, right? We have a longer time constant because our patient is more compliant. It takes them a longer time to get their lungs to empty. Kind of cool the ventilator actually measures that. At least I believe that's what that is. I think that's your expiratory time constant. I haven't looked at the Hamilton's manual to see if that's what it actually is, but I believe it is. Okay, so we're back to our normal, right? AutoPEEP of 15, driving pressure of 15, minute vent somewhere around 12, static 55, 57, whatever. We're back to our normal, right? This is where we were originally. Now let's look and see what happens if our patient gets more compliant. And once again, making dramatic changes for dramatic effect. So give it some time, let it adjust. This curve is actually starting to get deeper. Our time constant is lengthening. A lot of things are changing here. A lot of things are changing. Okay, I think it might be maxed out now. So, let's first look at our trap. 175. 118. Ooh. Let me see. 130, 125, 123, 120, 118. Big jump. So 118. I have to get my calculator back out. Haha. 67%. And what were we trapping originally? Like 50. Right? So our trap has gone up quite a bit. Now let's look at our other numbers. Our autoPEEP before was 15. Now it's about 20. Our driving pressure is only 10. Our tidal volumes are bigger. We have a higher minute volume. And our static compliance is even better too. So we can see how everything has changed. The lungs are taking a longer time to empty, which means we are trapping more and our driving pressure is lower. At the same time, because our lungs are more compliant, that pressure of 30 that we're pushing in, we're getting more volume out of that. So even though we're trapping more, even though a higher percentage of the breath is left behind in the lungs, we're still getting a bigger volume. Right? We're still getting that. Now, let's compare that to something else. Let's take this back to 100. Get it back there so you can see. Okay, so before we look at airway resistance, what have we learned so far? We've seen how changing Your parameters will change everything with APRV. Your T-low has a huge effect on both your mean airway pressure and your minute ventilation. Your P-high also has an effect on both, but also will change your driving pressure as well, right? Everything changes everything. And we've also seen that as your patient gets more or less compliant, your trap, your autoPEEP, everything's going to change, right? Your compliance gets better, you're going to trap more. Your compliance gets worse, you're going to trap less. Your autoPEEP will be less, right? Now let's look and see what happens if your compliance doesn't get better, but you have more airway resistance. Because higher airway resistance is also going to mean that they exhale slower, right? Because now, instead of, think about the balloon. Instead of having that saggy balloon that's not as elastic, the balloon might still be elastic. However, it has a really small opening. And if the balloon has a really small opening, it's still going to empty slowly, right? So let's look at really high airway resistance. So the compliance hasn't changed at all. But now our airway resistance is higher. Now here's my question. Does this look like the high compliance one? Kind of, but not really, right? Well, let's look at our trap. So, what do you notice already? 59.8. 38.3. 64%. So our trap is higher, but what do you notice? Our peak expiratory flow is way lower. Our peak expiratory flow is really low because our patient is obstructive. They have more airway resistance, right? So we can see our tidal volumes have dropped a lot. And our driving pressure has dropped. Our autoPEEP has risen. So, but our mean airway pressure is the same. So we can see that here we have an interesting phenomenon where we are trapping more, but we're also getting, we're trapping more and getting less volumes, but it's a little bit different, right? The lungs, the flow coming out of the lungs is not as efficient, right? Before, with the increased compliance, we were trapping more, but we were also getting more volume. Here, we are not getting more volume. We're getting less volume, but we're trapping more. So our minute ventilation has gotten worse. Our autoPEEP has increased, but our minute ventilation has gotten worse. Which is very interesting, right? But that is because there's an airway resistance problem now. Okay, so the last part of this video. First, we're going to talk about common misconceptions with APRV. And this one really irks me because I actually have heard this when I was a student from a preceptor at clinicals. A preceptor who I don't believe was a dumb guy, but was very lazy. He goes, well, APRV, it's so uncomfortable because you're using such high pressures and it's, it's inverse ratio and it's just so uncomfortable. Like, if you want to put somebody on APRV, you got to paralyze them, because otherwise they're just not going to tolerate it. No, we've already established APRV is the only mode of mechanical, I spelled ventilation wrong, haha, where the expiratory valve is open during inspiration, or the P-high. The patient can breathe whenever they want. They are not forced to hold their breath for a long time like inverse ratio. That is not what's going on. They can freely breathe whenever they want on top of P-high. Also, we tend to try to get the P-high lower than whatever the peak or plateau was before, right? We try to keep it at 30 or less, so even if the plateau is 35, we might try a P-high of 30 still. So really, the pressures are going to be lower anyway. And at the end of the day, what's more comfortable? Going with traditional low tidal volume, where they're getting a tidal volume of 400 and a rate of 20 with a PEEP of 15 in volume control and really high plateau pressures, or having a P high of 30, autoPEEP around 15, and the patient can breathe whenever they want during APRV. Like, what do you really think is more comfortable for the patient? The fact is, APRV is going to be more comfortable than super high settings. And studies show that APRV patients require less sedation and paralytics than patients with other forms of ventilation, because it is designed to be a spontaneous mode of ventilation. So this whole idea that it's uncomfortable, patients can't tolerate it, blah, 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 which I've heard multiple times, completely untrue. Completely untrue. Can patients have dysynchrony with it? I mean, patients can be uncomfortable, yes. But there really can't be dysynchrony if you think about it, because there's nothing to synchronize with. The patient breathes spontaneously whenever they want. The ventilator is not delivering any kind of synchronized breath. It's just going P high, P low at certain intervals, and the patient does whatever they want on top of that. Can the patient be uncomfortable with that? Of course. But I would say it's less likely than with other modes. And then finally, I've been talking about this since the beginning. Does it really work? The too long didn't read is probably. APRV is probably effective. It looks promising, but better studies are needed. There's no solid evidence yet. There's a lot of studies that show various kind of benefits, but those studies are either too small, too specific, or too flawed in other ways, so that it's not really good data, and we can't really make decisions based off of that alone. Now, going off of that, multiple trials have shown promising effects of APRV, such as increased oxygenation, reduced ICU length of stay, reduced vent days, better compliance, lower sedation requirements, and all sorts of things like that, like better VQ matching and whatever. However, once again, those studies are not really good data. And even on top of that, no study has shown a difference in mortality. Now, does difference in mortality always matter? The point is, there probably are some benefits to APRV, but the studies aren't there yet. And I'll just quote one of the journal articles I found. Quote, overall, although data on the use of APRV for ARDS appears promising, there is a lack of large randomized controlled trials showing consistent benefits. This deficiency has likely discouraged many providers from using APRV in standard practice. Furthermore, there is no consensus on the optimal APRV strategy, and one potential reason for the inconsistency of outcomes is the variability in the approach to initiating and titrating encountered in the literature. So my very unscientific opinion. APRV is a good option to have, but not everyone will benefit. Physiologically, it makes sense why APRV would be beneficial. You get a higher mean airway pressure while allowing the patient to breathe spontaneously, and you can still have some CO2 clearance. But are those advantages big enough of a benefit over conventional modes to make a true, actual difference in outcomes? There's no proof that it is. There's no proof that that difference is enough. I've seen plenty of patients make improvements on APRV, but I've also seen plenty of patients not improve on APRV. The lack of clear data-supported guidance for setting APRV makes it very difficult to use. We're essentially making educated guesses on how to run APRV based on what makes sense physiologically. The data does not prove any of it correct. None of it. Okay? And I think the problem with researching APRV is that there is no consensus on how to set it. We have things that kind of make sense physiologically, but we don't actually know what works best. 5, 10, 15 years from now, maybe they'll figure out, oh, this is how you really need to set APRV because of this, this, and that, and this is what actually works. Or maybe they'll say, none of it works, don't use APRV. I don't know. Well, the point is we don't know yet. But with that being said, It's never a bad idea to try it out if a patient seems like a good candidate. And if they don't tolerate, they don't improve, you can switch them back. That's going to wrap it up for today's video. APRV is a very complex topic. There's a lot that goes into it, especially managing and titrating APRV, because everything affects everything. But really, you just have to understand that the name of the game, the main point, is mean airway pressure and recruitment and oxygenation for those ARDS patients. That's the big point. You want to, we think, maintain a trap somewhere around 75%. Once again, no proof that that's the magic number, but some animal studies show there's less adolect trauma above 70, so that's kind of what we go off of. I hope you guys enjoyed this video. If there's anything else I can add to this, if you have any questions, please feel free to leave them in the comments, and I will answer what I can. And I will see you all next time.